Welcome to Healthcare Musings, a podcast dedicated to the discussion of critical care, the medical field, and healthcare in general. Here is your host, Dr. Hassaballa. All right, everybody. Thanks for being here. I'm recording this lecture, and it'll be up on the podcast next week, which should drop on May 6th. Anyway, so I want this to be interactive. Again, talk about nights in the ICU. So I want you guys to interrupt me. Feel free to interrupt me. Feel free to ask questions. I want this to be completely interactive and not just one-way communication. So first thing we'll talk about is tachycardia. All right, it's one of my favorite things. There's a lot of things in the ICU where you have to deal with abnormal vital signs and abnormal laboratory studies, and that's kind of the main things we'll talk about today is abnormal vital signs and abnormal laboratory studies. Okay. Because that frequently comes up in the ICU at night. And something that I struggle with as an intensivist is I'm presented frequently with an abnormal vital sign, whether it would be tachypnea, whether it would be tachycardia, we'll talk about tachycardia now, whether it will be some sort of agitation, and I don't always act on it. And a lot of colleagues from nursing have a problem with that. They want me to fix every single abnormal vital sign, right? They want it to stay within the parameters. Otherwise, why is the order saying notify me if I'm not going to do anything about it? And when I don't explain why I'm not doing anything about it, then it seems like I don't care. And so I think it behooves us as clinicians, as physicians, to sometimes, if we're not acting on it, explaining. So let me give you an example. I was recently on a telemedicine shift, and they called me with persistent rapid atrial fibrillation. Okay, I had given a dose of digoxin a few hours earlier, right? 500 micrograms of digoxin. They called me about 2.5 hours later. He's still tachycardic, and they want me to do something, right? And so I said, well, let's just hold off because I don't want to then give another heart rate medication, and then you're calling me back saying they're bradycardic and hypotensive, or now we call rapid response or code because they go into cardiac arrest. Why? Because I didn't give the therapy time to work. So I'd rather, and it's not like the patient was unstable. If the patient's unstable, that's one thing. But if the patient is stable, hemodynamically stable, clinically stable, awake and alert, not complaining of palpitations, not lethargic, not gray, not ashen, not diaphoretic, then you have time. Remember all the way back to the beginning of the rules of the ICU. Remember top 10 rules of the ICU. My number 1, 2, 3, 4, 5 rules of the ICU is don't panic. Okay, don't panic. If the patient is okay, regardless of the vital sign abnormality, it's okay. Take your time and think it through and take care of the situation if it deems being taken care of. If it doesn't deem being taken care of, then you don't necessarily have to act on the abnormal vital sign as long as there's no patient harm, right? And I can quickly cause patient harm if I just keep reacting to the vital sign. I can just keep giving digoxin, and then I can give diltiazem, then I can give metoprolol, and then guess what happens? They go into cardiac arrest. And now the patient that was awake and alert, tachycardic, but awake and alert is now potentially anoxic because I had to act on the number and fix the number. One of my other ICU rules is treat the patient. Don't treat the number always. You don't always have to treat the number. There are numbers you have to treat, like a potassium of 8. You should treat that number. Okay? And again, treat the patient. So tachycardia. First thing, think about, okay, so they call you, the patient's tachycardic, heart rate's 150. What's the first thing you need to do? Right, and why? EKG is the answer, and that's correct. Why though? Correct, exactly. You want to know, is this sinus tachycardia? Is this supraventricular tachycardia? Is this rapid atrial fibrillation? Is this atrial flutter with a rapid ventricular response? You need to know what kind of tachycardia this is, right? So now I'm assuming that they are hemodynamically stable. If they are hemodynamically unstable, then what do? They're tachycardic and hemodynamically unstable. Their heart rate's 160 and their pressure is 60. Unstable gets the cable. Is that what you guys said? Did someone across the way say anything? I missed that. I said unstable tachycardia. You got a cardio. Correct. You have to. I love it. Unstable gets the cable. So yes, if you are hemodynamically unstable with a tachycardia, I've never heard that before. That's awesome. You need to intervene. Correct, and it may be cardioversion. And remember, when you cardiovert a tachycardia, what do you always have to do? A tachycardia. Say it. What is it? Sync. Press the sync button. Yes. Press the sync button, because I did that one time in the ER when I was at your stage of training, and I forgot to put the sync button on, and I turned a tachycardia into ventricular fibrillation. And the patient was awake before, became unawake. And I was freaking out. And I shocked him again, and thank God he came out of it. And you can do it. If you cause an R on T, you can put them into 100%. You can put them into ventricular fibrillation, which can kill them. So absolutely, if we're going to cardiovert, make sure it's synchronized cardioversion, 100%. So good, very good. So we want to. It's a tachycardia. We need to determine what kind of tachycardia. Okay, if it's a supraventricular tachycardia, then it's one thing. So let's talk about sinus tachycardia. So if it's sinus, you get an EKG, it's 155 sinus. Now what? I tell you, I can give them 5 of metoprolol, 10 of metoprolol, and I can make the tachycardia go away. Is that always the right thing? Yes. No is the answer, and that's correct. No, it's not necessarily the right thing to just make the number go away. You can harm. Exactly. I love it. You need to find out why are they tachycardic, especially if it's sinus. If it's sinus, what is it? Is it agitation? And we'll talk about that. Is it fever? Is it the beginnings of hemodynamic instability? Because if you look at the oxygen delivery equation, which as a pulmonologist I know by heart, the oxygen delivery equation, right? The main determinants of oxygen delivery are hemoglobin, cardiac output, hemoglobin, and oxygen saturation. So the first manifestation of bleeding is going to be tachycardia before hypotension. So are they occultly bleeding, right? Is there something going on hemodynamically that you haven't determined? For example, somebody comes in with a cardiac cath, okay, they go through the groin, and then they call you at 3 a.m. Now their heart is 150. Is there what? What am I thinking? They just had cardiac catheterization. They were previously okay, and now they're suddenly tachycardic to 150, and it's sinus tachycardia. Tamponade, or what else? Hematoma. Where? Yeah, in the insertion site, right? Either it's a femoral hematoma, or yes, but usually those are distal, not proximal, right? You're talking about something that causes proximal. So cholesterol amyloid can go distally. Maybe you can get limb ischemia. That's definitely a possibility. The retroperitoneal bleed. You hit the femoral artery in just the right spot, it can bleed retroperitoneally, and you could be 3-4 grams down before you even know it, right? Before you become hypotensive. In fact, in hemorrhagic shock, hypotension is a late finding. It's late. We're not, and it's not no one's fault, right? If you don't determine when they call you and they're hypotensive and shock already, we're already several hours behind. Okay, so tachycardia is late. Hypotension and hemorrhagic shock is actually very late finding. Okay, the body can compensate, but the first sign could be tachycardia, right? So look at the patient, get the history, see what's going on. So is it fever? Is it agitation? Is it pain? Is it hemodynamic instability? All those things. And then if it's sinus tachycardia, I want you to determine the underlying cause and not just treat the number. Because I'm going to give you an example. I had a patient I was transferring to a higher level of care during COVID. Okay. He's going to get ECMO. And the nurse kept calling me about the tachycardia. And I just kept ignoring the nurse. It's fine. Calls me again, tachycardic. I'm ignoring the nurse. Calls me a third time. I fine, give him 5 of low pressure. The next phone call is, guess what? Blood pressure 70. And I start norepinephrine, just counterbalancing and counteracting the very thing I did. Because it's my fault, I succumbed to the harassment of the bedside nurse about the number. So don't do that, okay? If it's sinus tachycardia, determine why they are tachycardic and fix the underlying cause, okay? So we'll segue. So now if it's supraventricular tachycardia, okay, now we can do what? We can do a vagal maneuver. You can, if they're awake, and you can say bear down. Make sure they don't poop in the bed, because maybe they may not be able to hold on to it. But you can also do, and please don't do carotid massage. Please don't do that. Okay, I know that's technically in the book, but if they have a plaque and you break it off and they get a stroke, I've never done that. Please do not do eye massage either, okay? Because that's technically a vagal maneuver and you can cause retinal detachment, retinal tears. Please don't do that. So I would give adenosine. Correct. I would give adenosine in supraventricular tachycardia. Okay, what dose? 6 milligrams. Make sure you're in somewhere where it's a good IV and you're pushing it very fast, because adenosine goes away in seconds. Okay, and then if a 6 doesn't work, then you can do another 12 and another 12. Exactly, to see. And then it'll tell you, is this underlying a flutter? Is this just really SVT? Sometimes it'll break out of it, sometimes it won't. Now, if it's rapid atrial fibrillation, adenosine almost never works. I've tried it, it almost never works. So that's why it's important to make sure you know what kind of tachycardia it is. If it's SVT, true SVT, then adenosine may help you. In my experience, adenosine with rapid atrial fibrillation almost never works. It doesn't even do anything. Maybe it slows down a little bit, and then they just go right back into it. Rapid atrial fibrillation, okay? That's very common. A lot of people have underlying heart disease. A lot of people have underlying lung disease. Very, very common with people with COPD that have underlying atrial fibrillation. What do we do there? Again, if they're unstable, we are doing synchronized cardioversion. We're talking about stable rapid atrial fibrillation, hemodynamically stable rapid atrial fibrillation. What are we doing? Very good. You can give diltiazem. You can give metoprolol. You can give digoxin. Absolutely. If sometimes bolus will work, 1-2 doses of bolus will work. If it doesn't, then you can start a continuous infusion of diltiazem. Sometimes 150 of amio bolus would take care of it and do the trick. Sometimes you have to start and continuous infusion amiodarone, continuous infusion diltiazem. Now watch, you put them on continuous infusion diltiazem, they might become hypotensive. Okay, yeah, I mean, so you got to pick your poison, right? You got to pick your poison. If you really care about the tachycardia, then you might have to take the hypotension. Amiodarone you can get away. You don't have as much hemodynamic compromise, but not necessarily the case. Not necessarily the case. Okay. Now, say it's ventricular tachycardia. Again, unstable, we're giving the cable, correct? Stable ventricular tachycardia. What would you do? Stable VT. Amiodarone, maybe. Mm-hmm. What else? Lidocaine. Very good. Lidocaine. Now I have a story about lidocaine. I'll tell you in just a second. So yes, maybe look at the underlying cause. Are they having hemodynamic myocardial ischemia? Maybe you may want to get, maybe troponin to make sure it's not, 100,000 or something like that. And then they go into VTAC because they're actually having myocardial ischemia. So those are things. Now, lidocaine. I had a guy who had recurrent VT, just kept coming back and back and back and back. We started him. Cardiologist came by, said, lidocaine. We will start him at, I can't remember, 4 milligrams an hour or a minute, something like that. Okay. Several hours later, they call me into the room because he is completely obtunded, unresponsive. So much so that I had to intubate him because he could not maintain a patent airway. Okay. And hypotensive, and I had to start norepinephrine. I got a CT of the brain, negative. Hemoglobin, normal. Troponin, okay. What happened? Why did he go into shock and I had to intubate him for airway, quote unquote, I'm doing air quotes, airway protection. Airway protection is not a diagnosis. Okay? It's not a diagnosis. Encephalopathy causing the patient to be unable to maintain a patent airway. That is the diagnosis. It's respiratory failure, secondary to metabolic encephalopathy, causing the patient to be unable to maintain a patent airway. That is the phrase you have to put in your documentation, not airway protection. Okay, now we can say that between each other because we know what we're saying. But those two words, airway protection, is not a diagnosis. And why I tell you that? Because commercial insurance companies love to deny respiratory failure and they say airway protection is not a diagnosis. I have no evidence of hypoxia. You get a blood gas after they get intubated and the PO2 is 450. There's no hypoxia there. Your PCO2 is normal. There's no hypercapnia there. There is no respiratory failure. Well, being able to breathe needs two things. It needs pulmonary gas exchange, normal pulmonary gas exchange, and an open airway to get the air into the lung to achieve pulmonary gas exchange. So if they cannot maintain an open airway, either from obstruction or they're so encephalopathic that the upper airway reflexes are no longer able to maintain patency, that's respiratory failure. You have to document that in the record. Okay? All they go by is your documentation. That's it. Okay? So you just have to be careful. And if that's too much typing, then do a dot phrase or dictate it. But don't skimp on your documentation. Don't, because you're trying to get out on time. Figure out how to be efficient without staying after your shift. It can be done. It 100% it can be done. You just have to figure out how to do it without cutting corners. So that's kind of a side sermon on respiratory failure. But what happened? Why did that patient crash like that? Lidocaine toxicity. 100%. Lidocaine toxicity causes. Think about it. And recently, someone told me lidocaine is a local anesthetic, right? Well, in high doses, it's causing local anesthesia of the brain. The brain is a bunch of nerves, right? If you inject lidocaine into a finger, the finger goes numb. Well, high enough serum levels of lidocaine, and the brain goes numb. You're stopping sodium conduction in the nerves, right? So this patient had we got lidocaine level, it was way off the charts. Stopped the lidocaine, miraculously he woke up, came off norepinephrine, and got extubated the next day. So lidocaine toxicity should be on the lookout. BOLO, B-O-L-O. Be on the lookout. If you start someone on lidocaine, be very careful the dose you do because they can get toxicity, causing shock and mental status change. Yes.
This lidocaine was. I haven't really seen it being. Is it given more?
Usually it's a continuous infusion. Mm-hmm.
Okay.
Mm-hmm. So they'll do like a milligram per kilogram bolus, and then they'll do 1 to 4 milligrams per minute, if I'm not mistaken, as a continuous infusion. But you got to be careful that you don't overdose the patient. This guy was a little thin guy, and so that was way too much lidocaine for him. And we stopped the lidocaine, and guess what? He woke up. So just be careful with, just know that that's a possibility. And so if you suddenly get shock or mental status change on someone on lidocaine, it could very well be lidocaine toxicity. Okay, so that's for now. What other arrhythmia looks a lot like VT and VFib and is misdiagnosed? Looks a lot like VFib. No, just looks like VFib when it's not VFib. Now if it's unstable, you're cardioverting. But what arrhythmia looks a lot like VFib and it's not? No, that's not what I'm thinking about. But yes, but no, that looks like VTech. Torsade de pointe, yes, twisting of the points. Okay, again, a twist of the points. It looks a lot like I've been misdiagnosed as VFib. It's not. It's torsade. So rather now, if they're unstable, again, you're defibrillating. But if you can give what? Magnesium, you can abate. You can stop the arrhythmia before having to go to defibrillation, right? So pay attention. Know that torsade looks a lot like VFib, right? And so who is at risk for torsade? Like what can lead to torsade de pointe? Prolonged QT, exactly. Prolonged QT, and what can do it? Like 100 drugs, right, can cause prolonged QT. One of my favorite drugs for agitation, it gets all okay, is haloperidol. That prolongs the QT big time. A lot of the antipsychotics prolong the QT. Methadone prolongs the QT. A lot of antibiotics prolong the QT. I mean, the list is super long. So just be aware of the Zofran, Reglan, metoclopramide, ondansetron. All those drugs can prolong the QT. So which leads me to the next thing at night is the critical lab call. Okay, everyone, and every time I do a night shift, I am inundated with critical lab calls, and inevitably I'm going to be called about a low potassium, the potassium of 3.4, and then silence because I don't want to do anything about it. Now, in somebody who has a prolonged QT, okay, you may want to have a normal, quote unquote, normal potassium. But remember, the lab normal potassium is what? 3.5 to 4.2. So if the potassium is 3.6, that is a normal potassium. Where we got this notion, and it's not just here, it's not back home in Chicago. It is. I work as an teleintensivist across the country. Literally every ICU, I am tortured by potassium. In fact, one day I think I'm probably going to die from hyperkalemia. From everything that I've gone through my career about low potassium, I think it's going to be the cause of my death. There's a very funny story. When I was moonlighting, there was a nephrologist who was on dialysis himself. And he comes into the ICU, he comes to the ER, right before he arrests. He's like, check my potassium. I'm like, goes just like asystole, and he was a hyperkalemic. He did fine, thank God. It was a very funny story because we were laughing about it because he did fine, thank God. But he knew, he's like, check my potassium, and it was actually like 7.5 or something like that. But a low potassium, of 3.6 is not low. 3.7 is not low. 3.8 is not low. 3.9 is not low. Now, why are they calling us about a potassium of 3.8? Because in the 1980s, there was one article, I think in the Journal of American Medical Association, that talked about people with heart disease, like acute coronary syndrome, that tended to do better and have less arrhythmia when the potassium is 4 or more, or the magnesium is 2 or more. That's it. And ever since then, it's been perpetuated that not only just in the ICU, in the whole hospital, that everyone's potassium has to be 4. No, it does not. Everyone's potassium does not have to be 4. Okay? And I'm sure we could save tons of money by just not treating every single potassium that's below 4. In somebody who has QT prolongation, 100%. You want the potassium to be normal because hypokalemia and hypocalcemia and hypomagnesemia can lead to QT prolongation. In someone who has a prolonged QT for whatever reason, either congenital or medication-induced or iatrogenic, okay. But everyone else, no. And if it's not a cardiac patient, who cares? Have them eat a banana. I just, again, treat the patient and explain. That's a normal potassium. The patient does not have any risk of QT prolongation. I'm not going to treat that potassium, especially if they have renal disease, because hypokalemia is much easier to deal with than hyperkalemia. That is so much harder to get rid of than hypokalemia. I would much rather have a potassium of 2.9 in a patient with a creatinine of 4.9 than have a potassium of 5.9 in a patient with a creatinine of 4.9. That potassium of 5.9 is so much harder to deal with than a potassium of 2.9. Okay? And sometimes the Lokelma, the sodium, the zirconium, it takes a long time to work. And hyperkalemia can kill you. Many times, hypokalemia does not kill you. But hyperkalemia can, that's what they do with lethal injection. They inject potassium. Because potassium stops the heart. When they're in the heart, in the OR, they paralyze the heart with potassium. Okay? So I am much more afraid of hyperkalemia than hypokalemia. Right? Just like hypoglycemia is way, 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 way more dangerous than hyperglycemia. With the caveat that people come in with DKA and HHS with hyperglycemia in the hundreds and thousands, that's different. And hypoglycemia will kill you immediately. Hyperglycemia takes a long time before it can cause any issue, especially if you're not a type 1 diabetic. Okay? So all goes back to 1, not panicking, and 2, treating the patient. Okay? So you're going to get those, especially if you work inpatient and you're taking overnight, you're going to get the critical lab calls. Again, stop and think about, what are we doing? And honest to God, sometimes I put the protocol on because I just don't want to I don't want to get called about potassium. And sometimes it's not necessary. Okay, especially if they're not a heart patient, if they don't have any kind of arrhythmia. So just kind of know about potassium. Let me stop there and get any kind of questions or what else you guys want to know.
You have a patient, cardiac arrest, rapid response, or you get enough to do the whole lab work, inspect the lab, inspect all the changes, then come back, forced to inspect these numbers. At what point might residents say, yeah, we should probably look at this as the primary?
That's a very good question. So the question is, if you have someone who suffers cardiac arrest on the floor and you resuscitate them successfully, and then you take them to the unit, and then you're getting all these labs, and the high sensitivity troponin is 400. I expect that. Exactly right. I expect that. At the same time, I want to know, I kind of would want to know what the next one would be. If the next one is 400,000, that's different than if the next one is 550. Right? And there's no way to know that. And I can't tell you how many times where we get one troponin. But when you get a troponin, it's at that moment in time. Right at that second that you draw the troponin, there was no evidence of troponinemia at that moment. You don't know what's happening with the troponin unless you trend it, right? So if you're suspecting myocardial ischemia, and I can't tell you how many times, the next one, goes. Now we don't have, in my home shop, we don't have high sensitivity, so we'll have a negative troponin, and then we happen to check the next one, and it's 120, and you're like, whoa! Now I'm behind the 8 ball with myocardial ischemia, right? And time is hard, just like time is brain. So yes, in that case, I expect that. I expect the lactic acidosis. I expect the cardiac. I expect the renal failure. I may even get hyperkalemia. I just want to know, is that next troponin going to be, like I said, 550, 600, especially if somebody has kidney injury, or is it going to be 500,000? That's a big difference. It's a big difference. It's a different, correct. It's a much different trajectory of where that troponin goes. So you just want to know, and it's just another 1 hour later, and that's just another thing, and just to trend it. And then if you don't think in your heart of hearts, no pun intended, that this is not a heart issue that causes the cardiac arrest, then document that. Document in your record. The troponin is elevated. I expect this to happen in the aftermath of cardiac arrest. I do not, my clinical suspicion is that this is not acute coronary syndrome. Okay. So there's no need to get another one. Document that. Just document your thought process. We can't read your mind. Nobody can. So if you're not documenting your thought process, then complications are always retrospective. When we look at a case, we have the benefit of hindsight. I see the entire case after it's done, especially in a court of law. Okay? And it's so easy to nitpick and say, well, why didn't you do this? Why didn't you do this? Why didn't you do this? After the fact, when you know everything. And when you're seeing that patient at that moment, you have to document what you're thinking in your head, because we can't read it. And if your documentation is poor, it's only going to harm, number one, the patient, but two, you. Because especially in an adversarial, and we can even have another lecture about liability and litigation and all that stuff, because the plaintiff attorney is going to make you out to be a murderer. They're not going to be like, oh, we all make mistakes. That's not what they're coming after you for. When I read my first summons, I still remember my now 23-year-old daughter was a baby. I held her in my hand when they handed me this summons. And I made the mistake of opening up and reading it. And it made me, I was an intern at the time, like not even a 1 month old doctor, not even 1 month old. And they made me out to be a murderer in the complaint. The intern, I was the least person taking care of that patient. I was just doing the notes. They still made me out to be a murderer. And it affected me. It really did. So if you have to make sure that you document your thought process thoroughly. And if you don't want to type it out, listen, I can't type anymore. I have big fingers. My fingers get hurt. I'm old now. I can't. So I just dictate. And you can dictate 10 paragraphs in 10 seconds. Dictate. Pick up the dictaphone, put it on your phone. Here we have Epic and it has Dragon. Put it on your phone and just dictate and just write and write and write. This is why I'm not doing this. This is why I think it may be this. It could be this. And this is what I'm not doing. And then not only are you protecting yourself, but you're also, it comes across as a thoughtful clinician. Wow, this doctor took the time to write down what he or she was thinking. And they care. And in that case, if there's a complaint or a problem or a complication, well, the doctor did their best. Rather than you have nothing there, you don't write anything at all, or you don't, now it's easier. It's harder to, but even dating and timing in EMRs. If you saw the patient at 9:30 in the morning and they coded at 10, and you write your note and you don't pay attention to the time you saw the patient, and you write 11 a.m., they're going to say, well, where were you when the patient coded? But I was there. Yeah, but your note is timed 11 o'clock. How do I know you were there? How do I know you were not at home sleeping? If it's not written down, it didn't happen. Let me tell you. Employment agreements and stuff in the record. If it's not written down, it ain't going to happen. If it's not, okay, and soon, all y'all gonna get a job, right? If it's not in the contract, it ain't happening. They can tell you all you want. Oh yeah, and I have a whole on my podcast, the whole Getting a Job series. Let me tell you all, if they tell you in your mouth, oh yeah, partnership piece of cake and $5,000 buy-in, and then you become full partner, and don't worry about that. Yeah, it's all good, bro. If it ain't in the contract, it ain't happening. Okay? Because if they're gonna say it, but they don't want to put it in writing, that's a big red flag. Well, same thing in the record. If you don't document that I saw the patient at 9:30 in the morning, back in my days, in the dinosaur days, where we didn't have EMRs, you have to date and time. And you know what? Dating and timing notes saves you from a lawsuit. Potentially saves you from a lawsuit. No joke. Same thing in the EMR. If you saw the patient at 9:30, but you don't pay attention to when Epic, just when you open the notice, that's the time. So you have to pay. Oh, I saw the patient at 9:30, so I'm going to put 9:30. Then guess what? The note gets put in Epic at 9:30 in chronological order from when you saw them. And they say, oh, okay, you saw the patient at 9:30. They were doing okay. So when they had a complication, well, you were there and you attended the patient. It's different than if you were just. You have to pay attention. It's tough, man. There's a lot of things you have to do. Yes, it is. This is the way it is. This is reality. You have to pay attention to this kind of stuff. I mean, I can't make it different. That's the way it is. And if you do it, you just save yourself a whole world of hurt. And I have a whole story about that, but we'll talk about it later. But just document why you're not doing anything, or if not, just trend it, especially at your opponent, because you don't know the trajectory. It could be this, or just coming like that. And there's no way to know unless you repeat it. That's the thing. Questions? Yes. First is what? No. Before that, do you see the patient going from a blood pressure of 140 to 40 in 2 minutes? What's the first thing? It's a good A-line waveform. It's a good A-line, and your sats are your blood pressure is going from 140 to 40. Okay, with a good A-line. Your heart rate's now going from 140 to 40. Your sat is going from 100 to 40. What's the first thing you do? You don't panic. You don't panic. And you deal with the situation. If you have to push, if you have to treat that first scenario of hypotension, if you have to push phenylephrine, you push phenylephrine. If you have to get epinephrine from the crash cart, you get epinephrine from the crash cart, and just give it IV, because it takes time to get norepinephrine from the pharmacy, and so you know what's at your disposal and treat it. Yeah, in that case, because if they go from 140 to 40 and then their heart rate goes to 40, they're going to arrest, right? So you need to act. Yeah, then pull out the crash cart and do what needs to be done. After, you don't panic. Don't panic. I mean, that is because when you're panicking, you're frozen in fear. You're frozen. Now you don't know what to do. And so I'll give you a story about that. It was during the pandemic. Okay, I think I may have said this. This guy tried to kill himself by drinking Roundup. Okay, it destroyed his upper airway. I mean, it was all blood. The mucositis was horrific. He starts to desaturate. Now I have to intubate him. Okay, so I'm used to COVID patients being SATs 50s and smiling at me and looking at with the remote control on the TV. This guy was not like that. I'm struggling. His SATs are in the 70s. Okay, and and all I can see is blood. I can't see the airway. All I see is blood. So I just needed 30 more seconds to get the airway, but everyone around me was panicking and said, "SATs are 70, SATs are 70." So I stop and I try to bag. It's not working. So now the SAT's 50, heart rate's 50. Now I'm like, Okay, F this. Throw the thing. I get the tube. I see a little bit of bubbles. I go toward the bubbles, and thank God I got the airway, and he did not arrest. Inside, I was screaming. I was so scared. My legs were shaking, no joke. But outside, I was calm. Had I panicked, that guy would have arrested 100%. 100%. And there was literally a matter of seconds before he would have stopped breathing. Or no, his heart would have stopped. I'm bagging, and I can't. It's not, the sats aren't going up, they're going down. Because there's the airways full of air, full of blood, and I can't see. On the outside, I looked like I was calm. Inside, I was screaming. Literally, my legs were shaking. If you couldn't see it, because the bed was covering my legs. But literally, my legs were shaking. I was that scared. Okay, that's normal. Being afraid is normal in that situation. You can't let your fear overtake your judgment. You can't. So in that situation, number 1 is number 1, 2, 3, 4, 5 is you do not panic. And then you do what needs to be done, depending on what it is. If it's saturation, bag them. If they're on a ventilator, we're talking about vent desynchrony. We talked about this last time. If they are dysynchronous on the ventilator, you can always disconnect them from the machine and bag them and see what's going on. If they are super difficult to bag, maybe they had a mucus plug and now they can't. Now there's a mucus plug. Maybe they have a pneumothorax, right? And so you always, when you don't panic, you can just step back and look at the situation. But yeah, you're going to have pre-code situations all the time. After not panicking, then deal with the situation and know what you have in your armamentarium, right? Know if it's push phenylephrine, do it. Epinephrine from the crash cart, do it. No one's going to fault you. Your pressure is 40. I just want to get it up. Now, your subsequent pressure may be 200, but at least now you have a little bit of time to figure out what's going on, right? Get a blood gas. If they have an A-line, is their hemoglobin now 4 where it was 14? You know what I'm saying? Hypoxia, same thing. You throw them on, bag them. When I was post-call in med school, when I had contemplated a career in anesthesia, the post-call anesthesia resident would go to the PACU and for ECT, electroconvulsive therapy. And you know what we did? We didn't intubate them. We gave them pentothal and succinylcholine. And I just bagged them until they woke up. And the psychiatrist went from patient and just went shock, 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 down the line. And all we did was give them pentothal and succinylcholine and bagged them until they woke up. So if you can bag someone, especially if you have to intubate, if you can bag them, take your time. One time, this was Thanksgiving. I was working Thanksgiving when I was a resident, and patient came, threw up. There was vomit everywhere, hypoxic. I have to intubate her. Can you bag her? Okay. Like, yeah, she can be bagged just fine. I took my time. You think I want vomit on my clothes? No, I took my time. I got my gown, got my gloves, I got my eye protection, because the patient can be bagged and she's saturating just fine. I have time. Now, if they can't bag the patient and the PET sat's 50, then I just got to get in there and tube, just like that patient with the Roundup. I had to just throw everything down, just tube and just go through the bubbles and see what happens, right? If you have time, if you can bag someone who's hypoxic, you have all the time in the world to get the setup, to get everything, get the glide scope, get the ET tube, make sure it's working, get everything ready so that you have first pass success. A lot of times I use non-invasive as my bagging. If they're already on non-invasive, okay, why do I disconnect them from the CPAP and then bag them? Why? I just use the CPAP. I turn up to 100% if they're not already there. I let them work on and then as I get everything set up, and then boom, we give the drugs, take the thing off, intubate. I'm able to do all that. Why? I go back to my top 5 rules. Don't panic. No matter what, man. And sis, no matter what, don't panic. I can't stress that enough. Don't panic, because sometimes it does like that in a matter of seconds. Yeah, yep, it can. And they can arrest out of nowhere. Yep. And if they do, you know what to do, right? CPR, we know what to do. Relax. Don't panic. Yes, it is. It's very hard to do, which is why I write about it, why I wrote about it. And I put it in a book, because it's very hard to do. And you know that guy with the Roundup, everyone around me was panicking. and I let their panic get to me. I should have ignored them, and I just needed 10 more seconds to get the airway. I should have ignored them. I didn't. I let their panic get to me. And I should not have done that. Thank God he did okay. Thank God he did okay. But people will say when they see me in a crisis situation that I'm disengaged, that they can say, well, you look disengaged. I'm not disengaged. I'm trying to remain calm. I'm trying not to panic. Now, also, I don't want sputum in my face either. So maybe I'm not going to be right in there right until I'm getting my PPE on. I don't want vomit or blood in my face either. I got to protect myself, man. I got to protect myself. So as long as I can, I'm going to protect myself, get everything set up so I can do it right the first time. Because if someone's hypoxic and you tube the esophagus because you're in a hurry and you're Mr. or Mrs. Macho and let's just go in there and be Mr. or Mrs. Cowboy and you tube the esophagus, that is 10 times worse than taking 1 minute to get everything set up as long as they can be bagged and you do it right the first time. That is, to me, 100 times worse. Okay? You put a line and, even in a code situation, you put a line and you're just Mr. and Mrs. Macho and I don't need ultrasound. Ultrasound's cheating. That's I've heard some doctors tell me. And they stick the line into the artery and then infuse vasopressors. And I'm like, how come the leg is white and the other leg is pink? That's weird because the central line that I thought was in the vein is in the artery. Mr. and Mrs. Macho didn't want to use ultrasound. Listen, if y'all going to stick my groin, I want you to use ultrasound. I want you to cheat. If you're going to stick my neck with a needle, you better damn use ultrasound. I don't care how many years in practice you've been. Me too. I don't care. When back in the dinosaur days, we didn't have ultrasound. So yeah, I stuck a lot of carotid arteries. And it's the way it goes. Now, there's no excuse. There's no excuse. It is standard of care. It is standard of care. You have to use ultrasound. You have to see where you're going. Who would drive with blindfolds on? Who would do that? Even if you have a self-driving car. Who would do that? No one would do that. So why are you doing it to a patient? You're sticking a needle in their neck. You could go through, the textbooks tell you where the structures should be, but not always where they are. Sometimes the IJ is on top of the carotid. Sometimes the carotid is on top of the IJ. Sometimes the lung is right there. If you don't know if you don't look and see where you're going, how do you know? You could go through the IJ into the carotid artery. I saw a cardiologist put a cordis into a carotid artery. And then I'm like, he's like, oh, yeah. He just pulled it out. I'm like, if that's my carotid artery, don't do that. And the way you'd not do that is by using ultrasound. So you much better to do it right the first time if it takes you 5 more minutes than to be Mr. and Mrs. Macho and hurt the patient. Always wrong. Yes.
Question. That's like your acutely.
Correct. That's your acutely decompensated patient.
BiPAPing, we're going to see how they look. It could go either way. As a resident, especially if you're rising control, when do I pull the trigger? When's the right time?
So that's a very good question. Non-invasive mechanical ventilation works really well. Okay? In the right patient. The patient has to be awake, alert, maybe not necessarily right away, but has to be awake enough to maintain a patent airway. Okay? If they're not awake enough to maintain a patent airway, they're not. If you have somebody who's completely unresponsive, okay, you get a blood gas and their PCO2 is 120, and you're rubbing them, sternal rubbing them, they're not maintaining a patent airway. You don't throw BiPAP on them, you intubate them. Oh, opioid overdose, right? You're coming in, you get their blood gas is 6.8 and 155 PCO2. I'm going to put some BiPAP. No, not if they're completely unresponsive. You tube them. Somebody who's a little bit in distress, a little bit hypercapnic, but still awake, talking, that's the one where non-invasive works well. But you keep a very close eye on them. If it's not working, it'll manifest in the first half hour to an hour.
I hear people say get the blood gas 30 minutes, an hour later, to help you decide. I think that's good data to have.
Get the blood gas, yeah.
But really, I think, at least for me, I would look into the room.
Treat the patient, exactly. So you can get the blood gas, right? And maybe the PCO2 goes increases a little bit, right? To maybe it's 85, and then now it's 73. But you look at the patient and they're struggling, right? It shouldn't be 73. It should be 43, but it's not, right? So if they're still in distress, and we learned in COVID that just being in respiratory distress in and of itself can cause lung damage, can cause worsening lung damage. And because we were so afraid to intubate people, which in COVID was a lot of times a death sentence, we would keep people on non-invasive a lot longer than we should have. Looking back, we probably kept people on non-invasive longer than they should have. Because we tube them, they're dead. Almost all, so many times we tube them, they die. So I don't want to tube them. But I'm keeping somebody on non-invasive for a long time where maybe I shouldn't have. We're learning, right? We learn. So if somebody's in major respiratory distress, if they're not improving rapidly, then you just have to proceed with intubation. Non-invasive works great for somebody who's hypoxic. It's great for COPD exacerbation, great for heart failure. It's great for pneumonia. There's been research on that and literature. At the same time, you have to keep a close eye on them. You have to make sure that they are responding. If they are not responding, and first, before that, you have to make sure that they're an appropriate candidate. If they are if their GCS is 3, don't throw BiPAP on that, because you know what you're doing. Guess where all the air goes? Yeah, where does the air go? If they can't even maintain an open airway, the stomach. So now you ever see those big gastric bubble? Why? The air goes in the path of least resistance. So now you have a distended stomach, and if they're not awake, and then they vomit, and now you're dealing with aspiration. Now you're in a worse situation. So if they're not appropriate candidates for non-invasive, don't even pull it out. Don't even try. They have to be an appropriate candidate first, which means they have to maintain a patent airway, okay? And then you can try non-invasive. It works great. It has saved a lot of people from being intubated, but they have to be appropriate. And then if you try it, if you're kind of like on the fence, then you're watching them very closely. 20, 30, no more than an hour. And the blood gas doesn't mean anything. If I walk in the room, treat the patient, treat the patient, man. If I walk into the room and the patient's in extremis, I don't care what the blood gas shows. I'm going to intubate that patient. That makes sense? Rather than, but the blood gas is getting better. The patient's not getting better, but the blood gas is getting better. Who cares if the blood? Don't even get a blood gas. Sometimes too much information is dangerous in the wrong hands. But the blood gas was improving it with the patient. The patient could not even hold two words together. And they're using accessory muscles, and their abdomen is paradoxical breathing. That is not an appropriate candidate. That patient has to be intubated. So I don't care what the blood gas shows. Don't even get it. Don't even get the blood. If you're not going to do anything with a test, don't get the test. I can't stand it when I'm taking call and people just trend troponin. They're not doing anything about it, but they're trending troponin, and I get called. Yeah, doctor, I'm critical troponin. Okay, and then worse, you don't sign out to your colleague what to do about it. Like that's at the very least, if you're going to check serial blood tests and you sign out to your colleague at night, tell them I'm getting hemoglobins every 6 hours. If the hemoglobin goes below 7, then I want you to transfuse. Tell me what to do. A lot of times we don't tell, we just trend the labs, and then the person at night gets the critical lab, and then I don't know, okay, what am I doing with this information? If you're not doing anything with information, don't just get it for academic interest. If you're not going to do anything with the test, don't get it. When I was in the office as a pulmonologist, lady comes in with a pulmonary nodule. It's 2 centimeters. She has a 30-pack year history of smoking. First question is what? What do you think I ask her? Uh, yeah, but after that, exactly. If this is cancer, are you going to do surgery? No. Are you going to do radiation? No. Are you going to do chemotherapy? No. All right. Have a good day. Who cares what it is? If you're not going to go through the treatment, then now, if the patient can't sleep at night because they're worried this is a cancer, maybe I'll do a biopsy just to tell them. And even then, I'll say, but if you're not going to do anything about it, who cares what it is? Live your life. So if you're not going to do anything with the information of a test, why are you getting the test? Why are you getting an x-ray? To follow pneumonia. You know, pneumonia can take 8 weeks to go away. Why are we getting x-rays every single day? What are you doing differently? Blood gases. Same thing with blood gases. If you're stable on a stable mode or they're improving, their FiO2 is coming down and everything's going, why are you getting blood gas every single day? What are you doing with that information? Why are you doing that? Why are you getting hemoglobins every 6 hours if you're not going to do anything about it? So at the very least, out of common courtesy, if you're going to trend labs, tell your colleague who's covering you at night so you can go home and rest at home, okay, that, like, what am I doing? So that is my cue. I think we're over time. It's 1:15. I'm a hard stop. So let's do this again. Okay.